We're going to talk about pharmacy spend and ways that you can control that pharmacy spend going forward. This is a pretty big unknown when it comes to healthcare expenses. How does it work? And so hopefully I will be able to share with you some things that will be helpful and meaningful. I'm going to keep this brief. We've been on a lot of Zoom calls this last 18 months, it seems like. So I just want you to sit back, relax, just listen to what's going on. And the biggest thing I can say is just because you've never heard of it before doesn't mean it's not true. It just means you haven't heard of it before. So with that, let's get started. So I am the managing partner for the Millen Group. We're based in Richmond. I am a benefit hacker, which means we like to find new and creative strategies. We get frustrated with what is being implemented in the industry, so we have some new ideas, and we've been around for quite a while. I want to start with a disclaimer, though. What I'm about to share may be subject to your own interpretation. These are based on my experiences, the connections I've developed over the last 20 years, the resources that I tap into to try to keep asking the question, why is it that way? How can we make it better? You know, I may say something wrong on the webinar. I try not to, but I may slip up, and you should always get your own advice. That's always a good thing to keep in mind. However, we've been around for 20 years, and we have a number of clients that trust us, and so I think we have some pretty good things to share. So first, let me get right into it. Why should you care about pharmacy? These are the 4 buckets of costs in your pharmacy, in your healthcare spend generally. This is for Milliman. So 27% prescription, 30 hospital, 20 outpatient surgery, and 20% primary care visits. So essentially, when you look at the money you spend in a year for your healthcare, whatever that budget is, so whether it's $100,000 or $5 million, or last week I talked to a company, they're spending $2.6 million. I said about a third to them on the phone, the CFO, about a third of that is going to prescription drugs. And do you have any idea where that's going? And the answer was no. And so not only is it a major piece, but it's the fastest growing piece.
Teresa Febres.
Join the meeting.
That's what's of concern. It's the fastest growing sector of those 4 buckets. That is the fastest growing. And I don't know if you know what the next one might be, but the pharmacy is the fastest growing. The second is outpatient surgery. It's really skyrocketing as hospital systems tend not to want to keep you in-house too long. And primary care is kind of primary care. It's been pretty flat. So your pharmacy is the biggest spend, and it's the fastest growing. The other reason that you need to pay attention to this is that a lot of your employees are covered members, I'm going to say. So not just employees, right? You have an employee with their spouse on your plan. That's 2 covered members. You have their kids, 6 covered members. They're taking at least 1 prescription. Many take more than 2. And here's a stat I pulled off of Google just the other day. 70% they're saying are taking at least 1. Talk to someone that has high blood pressure issues. Sometimes when the first med doesn't work, what do? They give you a second one, and it works in conjunction. What do they do if that's not working? They give you a third one, all for the same issue. And so this isn't impacting a lot of a significant majority. So number one, it's growing in cost, which is a concern. Number 2, it's of value to people and the members at your companies that are going forward. 3, the costs continue to soar. And, you know, big pharma makes a lot of money. And with that money comes influence. And one of the things you've noticed in the last 12 months, maybe 18 months, is transparency. A lot of talk about transparency, especially when it comes to pharmaceuticals and hospital systems. And this is just one particular drug class. This is insulin. And this is from 2012. I pulled this right online to 2019. You can see the cost of the insulin is going up 140%, but the net price of the base cost of the drug is going down. So that spread is widening. And so there's tremendous money. Why is it when you turn on your TV, you can't get those jingles out of your head because they're all about the pharmacy drugs? And so, you know, there's so much money, and you walk into your doctor and you go, hey, I want that. I want to look like that person run down the beach that doesn't have skin issues anymore, whatever it might be. So there's so much influence. And when people ask me, the number one thing they ask is, why have we not heard about this before? Why are we not being told about this? And I think you can guess what the answer is. It's money. There is so much money in this particular issue. And let's face it, we as Americans are getting maybe a little sicker over time. We're gaining a little more weight, a little less exercise, gaining a few more pounds. And so these issues will continue to grow. So with that baseline, very quickly today, I'm going to keep this a short webcast. There's three things. I want to talk about how does the system work? Because if you don't understand what's going on behind the curtain, if you don't pull back the curtain and have at least a little idea, then you're not going to be able to see the solution. The second we're going to talk about is how do you get visibility into your claims? When you're spending $500,000, $1 million, $2, $3, $4 million, $100,000 a year to the health insurance companies, how do you find out where that money is being spent? And three, I'm going to give you some steps that you can take right away. So with that, let's talk about the system. It's very complicated. It's very integrated. Lots of people, lots of players, lots of connections. If you look at healthcare, the healthcare system itself is, I think I read online, is a $4 trillion industry, and insurance is part of that, right? And it's so complex. The pharmacy network is integration of manufacturers and pharmacy benefit managers, and then you have the doctors and pharmacies and the lobbyists and regulations, and there's more than just five here. But the one I want to talk about is pharmacy benefit managers, because this is the one that you actually have potentially some control with. Not everybody, but potentially. So let me talk about and define what is a pharmacy benefit manager. Essentially, to keep it simple, think about a prescription drug, Humalog, which is an insulin for diabetics. You have someone that makes the Humalog, that manufacturer, and then you have this supply chain, and then you have the end user, which is your employee or your members on your plan, right? And in between the manufacturer and when you pick it up at the pharmacy is a whole bunch of players. One of those major players is a PBM, pharmacy benefit manager, and they manage the claims, they manage the process, they control the formulary, meaning when you have your card and you go to pick up a prescription, is the cost only $10 a copay for $10 for the prescription, or is it $150 based on which bucket of formulary they put that in? And this chart is fairly recent, explains that where the majority of the power is held, it's in these three top managers. So you have CVS Health, Caremark, you have Cigna, which includes Express Scripts, and then you have Optum RX, which is United Healthcare. So we have United Healthcare as one of our plans. If you look on the card, sure enough, there in the little box, it says Optum RX. That is the pharmacy benefit manager that they use for that process. So you need someone to manage it. And I'm going to dig a little deeper into this because you'll notice it drops off pretty quick. So the top three is about, 77%. It's a lot of concentration. Just as a side note, a lot of times we have to use those benefit managers. If you're a smaller company and you don't have a lot of extra options, you may need to go with the embedded pharmacy manager in the medical plan you have. You sometimes don't have a lot of choice. But as you start to get a little bigger, you have over 50 people on your plan, 100, 200, 1,000, 5,000. You have lots of options. And one of the things I'll talk about at the very end is we want to use the pharmacy benefit managers way down here at the bottom, these all other PBMs. Yes, they have small market share, but they're really efficient in terms of how they price things. And so that is the market, the PBM market. And I'm going to just dig into one piece of this because this kind of explains why this system is so messed up and why there's not transparency. There are at least 32 ways, probably more by now, that the pharmacy managers will hide revenue, meaning they can place this revenue in different pockets, whether it's rebates or claims or higher AWPs. All these different buckets are ways that they can hide the revenue. And so when you look at how much they make, you're not quite sure what you're seeing because it's moving. It's a moving piece all the time. These are all ways that you can save money. If you find out, how do I control the rebate? How do I use a partner from my company that is transparent about what rebates they get whenever they whenever they offer a prescription from a manufacturer? So just high level, You can see just on this, there's lots of different ways. So I'm going to show you a very simple example. I'll talk about Humalog just a second ago. So Humalog is a very common insulin for diabetics. And this little shot right here, this little screenshot is from a claims report from one of my clients. We're able to get claims data. So if you have the right partners and the right fiduciary vendors that you work with, they will tell you not necessarily who's using the Humalog, but how many and what is the cost. So this is the access that we have for this client. And you'll notice at the bottom, it's the top 6 drug for them. You have one person getting 5 prescriptions paid at $25.56 at a cost of $511 per prescription. To make that drug, it's essentially about $250 from the manufacturer. The other $261 is all of the markup. So the supply chain is actually making more than the manufacturer. And you will see examples of this across the board on lots of prescriptions. And so what's happening is that spread is growing. And guess who's paying for that additional cost and excessive pricing in the system? It's the employers. And it's the employees. As those costs have to be absorbed under the plan itself, then those costs are pushed forward in terms of renewal increases in skinnier networks and so forth. So a lot of that markup is not even going to the manufacturer. So that's a simple example about how this is a very dynamic process and how these claims can hit. In this case, it's $511. Every time someone gets a prescription, whatever bucket of money you send, it's into that bucket of money. And if you spend too much money at the end of the year versus what you've paid in, you get an increase. It's very simple. The next thing I want to talk about is the 3 letters. So you have a BIN number and a PCN number. So what is this all about? So if you look at your medical card now, whatever you have, and if you have prescription coverage, you will have somewhere on that card something that'll have BIN in a 6-digit number, PCN, and then some letters and numbers and a group number. I'm showing you here a GoodRx card. So here's another one that I have just as a sample. Again, there's a BIN number, PCN. Why does this matter? Because a lot of people don't realize how GoodRx works. They're like, it's a free card. Why are they giving this out? Why are they showing me Kroger is $5 less than Walgreens and I can run down and use my prescription? Because they have partnered with a pharmacy benefit manager. And the way you know it is the BIN number. When you go to the pharmacist and you hand them your card, what they're doing is they're typing in their system the bank identification number and the product number. And those work together essentially to say, how much is the Humalog? Is it $511? Is it $1,000? And whatever the number is, whatever that coding is what's charged to your plan. So when you go into the pharmacist and they say, John, you need Humalog, you're on a high deductible medical plan, so you got to pay out of pocket, and your cost is $850 a month. And they say, well, I can't do that. And they go, well, you can use GoodRx, and they scan this number, and they put that BIN number in using a different pharmacy benefit manager. But using GoodRx, John, it's only going to be $511. And so basically, they have intercepted the existing relationship on your medical card and use these guys. And that's why when you do that, you will hear the terms, that claim is not counting against your medical claim deductible. It's not part of that bucket that you are working with. You're using a different bucket of money, and so that will not go towards your deductible, but you might end up saving hundreds of dollars a month, so it may be worth it. That very simply is when you change a pharmacy benefit manager, how the system works, it's essentially those little codes. That's all the pharmacist needs. In the system, those 32 different buckets, remember we talked about this, that whole complex web starts kicking in, and your employee or their spouse or their child may only have a copay. It may only be a $40 copay to them, but your medical plan claims bucket, which is this third here. Remember we talked about this bucket right here, starts growing and growing and growing, and eventually you're going to have a cost increase, a price increase, and cost shifting because you're not collecting enough premium, and a lot of it is coming from prescriptions. Let me show you. I just got off the phone with, and this is a report from one of our other clients, and I don't know if you can see this very well, but that yellow slice, this is 5 months of claims. 85% of their claims is pharmacy. 85%. And we dug in, and you can see generic versus brand. We can see the cost per prescription. So this is well above 27%. The other one we just looked at right after this one, I think the pharmacy was 50%. So understanding how these pieces interrelate will help you maybe get control depending on what size you are currently operating. So I hope this is helpful. If you have any questions along the way, just put it in the chat box and I'll go ahead and try to answer those at the end if we have time. The other is, so the first is understanding the system. The second is how do we know what our claims are? How do we monitor that? And what I've learned is the funding type, how you fund your healthcare spend, is sometimes more important than how big you are. A lot of people we talk to think, well, I'm too small to get visibility, or I'm this to get visibility. And what I found is it's more about how your claims are monitored and funded versus how big you are. So I'll give you an example. So fully insured means you have the healthcare provider, an integrated pharmacy benefit manager, the claims, the admin fee. You're basically giving most of the risk over to them. And then every year they're going to give you usually an increase based on a number of different factors. So if you have a small company between 2 and 50 employees, fully insured, you don't have any claims visibility. I talked to, I don't know, 2 weeks ago, someone, they had about 55 employees on medical, spending around $500,000-$600,000 a year. And I said, can you tell me where that money's going? And they said, no. I said, you're writing a check, essentially 40 grand a month, and you have no idea where that money's going because you don't have any visibility, pharmacy claims or any claim. Even on the mid group, so if you have between 51 and 99, there's basically no claims visibility either on that. And even if you're a larger company, over employees, there's limited visibility, and depending on how big you are, you start to slowly get access to visibility on claims as you get a little larger. But most companies have less than 100 employees, and there's no visibility. And in this model, to be honest, the insurance companies don't want to give you visibility, right? They want to, they want it to be a surprise, and they just want to manage it, and they make a lot of money on the fully insured funding side. Let's compare that to, other than fully insured, there's lots of different other types of funding. There's self-funded or self-insured. There's level funded. There's reference-based pricing. And so you have more data when you move to that funding type than you will with fully insured. And this is another client of ours, and you'll see here, it breaks down where the tiering is, what tier bucket it's in. And in this case, Humalog is being charged at $842. So how is that, how is that possible? It's basically the same thing. In one company, they're getting charged $511, the other company $842. And this happens across the board. So I'm not suggesting that everyone should be self-level or reference-based funded. I'm just suggesting that that is a big characteristic to start getting some transparency back. And it's not a fit for everybody, but it's something that a lot of clients, a lot of companies we talk to are scared about. And it's just a different way of managing the risk versus a fully insured platform. So I would just say, don't be scared of that. Be open-minded. It doesn't mean it always makes sense for you, but you should have an idea of where you're going into the future. So here are 3 steps, kind of wrapping up. I'm at the 20-minute mark. 3 steps. What I would do first is take a look at your existing pharmacy coverage. Is it sufficient? You might have copays for pharmacy coverage. You might have a straight high deductible plan where there's really no copay and it's whatever the market price will be, the discounted price. Take a look at it. look at your demographics, look at your workforce, look at who you're trying to attract and retain, and understand the market now is in need of good quality talent. I think every company I talk to, they're trying to get good people, which means you may need to steal them from somebody else. And I can tell you firsthand, I've had conversations with employees before working for one of our clients, was referred to me. They wanted to understand their medical benefits before they took the job offer, and specifically the pharmacy coverage. In the past, the employer had no pharmacy coverage. We put in a buyout plan that at least had some really strong pharmacy coverage, so they were co-pays, because this particular employee was spending hundreds of dollars a month where they were, and they were moving to an environment where it was $40 a month. So take a look at that pharmacy coverage and see, it may make sense to have a buyout plan, or it may make sense to have one plan with that coverage. I would say consider alternative funding. You have fully insured, self-insured, level funded, reference-based pricing. And this particular sector of healthcare is changing very quickly, and so a lot of the carriers are reacting. And then third, I would say, if it's appropriate, and again, not every company can take advantage of a custom health plan, but we can help build. Basically, we take the components and we find our own pharmacy benefit manager that is a fiduciary, that pays on a per script basis, not a floating schedule, has transparency, and we can basically put the pieces together of a health plan. And not only can you dictate the cost better, but you can also control the coverage, and a lot of times the coverage is better. So again, not a fit everywhere, but certainly something to think about. So hopefully that was beneficial. I will wrap up with this. There is a couple ways we can help. We're certainly willing to talk to you later about anything that we talk about. We can actually do a little bit of a pharmacy spend analysis. For the right size company, we can do a 5-year projection. We can estimate based on making some changes to your pharmacy spend, what that would look like. A lot of times it's, in the right scenario, anywhere from 15 to 30% savings just by looking at your pharmacy spend. There's no cost for that, no broker of record letter, and we'd be glad to do that at any time. And lastly, here's our website, millingroup.com. Lots of great resources on there. Hope you can find some value there. Articles, podcasts, resources that are available to you. And so with that is it. I don't see any chats in the chat. So thank you for coming. I appreciate it. If we can ever be of assistance, just let us know. Have a great day.